I'll be discussing acute Achilles tendon ruptures and focusing mainly on the surgical management. This is probably one of the most common tendon injuries, and it occurs mainly in the male patients between the ages of about 30 to 45. Now, it classically occurs in any kind of activity or sports which requires or involves explosive acceleration. So if you look in this video here, you've got this athlete, and if you look closely at the left foot, as she explodes to push off, you see how that tendon fails and contracts up into the calf. There's usually some pre-existing tendinopathy in this tendon. So classically, it occurs in the so-called weekend warrior. This is your middle-aged person who still enjoys partaking in his impact activities, but isn't really keeping up with his fitness, core strength, and flexibility. Also, be careful with quinolones. Whenever prescribing quinolones, make sure to warn your patients that they are at risk of developing ruptures, especially of the Achilles and the quadriceps, for up to a year after using those antibiotics. So how do they present? Classically, this patient will come to your office and say he was playing some sort of sport like soccer, and he suddenly felt like someone kicked him or hit him in the back of the heel, which resulted in him falling to the ground. However, when he looks around, he can't see anybody near him. They may also report hearing a loud snapping or gunshot sound. And what is also very important is at the time of the injury, there may be pain, but often this pain subsides quite quickly, and all that remains is really swelling and bruising. And it's for this reason that this injury is still quite often missed, either because the patient doesn't seek medical attention, but still primary physicians are also misdiagnosing this because there isn't usually much pain associated with it. Now, this injury is a clinical diagnosis, and what we look for, so first of all, the so-called palpable gap, as you can see in the picture. In the acute phase, this may be difficult to see because of the swelling. The other common test is the Matel's test, where you ask the prone patient to flex his knees to 90 degrees. And if you look at the right foot in this picture, that's got the so-called normal resting tension of about 10 to 20 degrees of equinus. If we look at the left foot, that foot's actually in more of a dorsiflex position, therefore he's lost that resting equinus position. I'm sure the most common test is your Simmons or Thompson test, and this is performed by first squeezing the calf on the unaffected leg, and you should see the foot plant to flex. Now, with an Achilles rupture, the muscle belly has lost its continuity and attachment to the calcaneus. So by squeezing that muscle belly, the force is no longer transmitted to the calcaneus, so you don't see any movement in the foot. Now, as I mentioned, this is a clinical diagnosis, and I don't think actually ultrasound is necessary for the diagnosis, and often it can be confusing. I often get a report of the tendon being partially ruptured. And why this happens is, if we remember when we operate in these patients, we look at this ruptured end, you've got those frayed ends overlapping each other. And this can give an appearance of continuity on ultrasound, which gives the report of the partial rupture. This ultrasound should actually be done dynamically with plantar and dorsiflexion of the ankle to make the correct diagnosis. X-rays are not routinely used for these ruptures, but be careful of the insertional Achilles rupture. So when examining these patients, I always palpate the insertion. If there's severe pain or swelling, then I would do an X-ray to look for these kind of avulsion fragments, which help me make the diagnosis. So when it comes to operative management, there's basically two main techniques that we've learned about, so the so-called open and percutaneous. Now, the open is where you'd use an extended excision to expose, and you can see both tendon ends. And under direct vision, you can place your sutures, and you can visually confirm that you get good apposition between the tendon ends, therefore restoring the normal tension in the tendon, and this theoretically would give you a more predictable outcome. The problem with the open procedure is that there's a high incidence of wound complication rates in the literature. And because of this, the percutaneous technique was already described in 1977. And here you're basically passing your sutures percutaneously through some small stab incisions, but you're not opening up the rupture site. So when you tension your sutures, you're not really guaranteed that you've got good apposition. And as a result, there is a higher re-rupture rate. And more importantly, there's an increased incidence of sural nerve injury. And as a result, in the kind of 2000s, the so-called limited open procedure became popular. And basically, you got the best of both procedures, the open and the percutaneous. And what you do is you make a small incision directly over the rupture site, so you can visualize the tendon ends, but you're passing your sutures using specialized instrumentation. And this instrumentation allows for the sutures to be pulled through within the peritoneum, therefore limiting the injury to the sural nerve. And because you can visualize these stump ends, you can make sure that you've opposed the tendon ends appropriately and thereby restoring the tension. Now, the advantages is that you've got far less surgical dissection, you don't disturb the blood supplies as much, so therefore you should get less wound complication. The limitations are that it's best to do this procedure within 3 weeks of the rupture. After that, you start getting some adhesions, and it can be difficult to release those adhesions to do the small incision. Also, this technique is not amicable to manage insertional Achilles ruptures. Now, sometimes it's more important to know when not to operate rather when to operate. Now, these contraindications are important for when deciding operative management. So beware of the diabetics, the chronic oral steroid users, smoker, any vascular compromise, or poor soft tissue. Bergerman showed in his paper that diabetics and steroid users have up to 42% complications. So who's the ideal candidate? In my practice, this is the middle-aged patient, preferably below 60 years of age, who is still active or an athletic individual. I'm also very keen in proposing operative management if the rupture is more than 3 days old. We've got good evidence in the literature that if you want to have the maximum effect and outcome with conservative management and decrease the re-rupture rate, that your conservative management should be started within 3 days of the rupture. So I'm going to go through my technique of doing an open repair. So I use a medial paramidline incision. This allows me to avoid the sural nerve and injuring it, but also allows me to visualize a plantaris tendon. And if it's intact, I'll incorporate it into my repair, either with a side-to-side anastomosis or weaving it through the repair site. So very important, make a full thickness incision down onto the peritoneum. Don't undermine the skin incision. As I say, you want to limit any wound complication. Always use blunt retraction and deep retraction. You then carefully open the peritoneum, and here we visualize the Achilles rupture, and you can see those frayed ends overlapping each other, and that's what gives that appearance of continuity on ultrasound. But as soon as we lift up one of the stumps, we can see it's a complete rupture. Now, with regards to suture material, so historically we used to use Ethibond, which is a non-absorbable multifilament, and the reason we did it is this was a large tendon, it's got to take the body weight, and we were concerned that the suture might break. But subsequent biomechanical studies showed that the failure is not in that the suture material breaks, but rather cuts out through the tendon. We also now know that these non-absorbable foreign bodies that we can implant can cause chronic inflammation, irritating the patient and the wound. And if you were to get infection, it's quite difficult to debride this non-absorbable material from the Achilles. So I routinely use an absorbable suture, and I prefer using something like Vital because it's easier to lock the knots. So what technique? I personally use a combined modified Kessler and Krakow, and as you see, there's multiple different techniques described. So I start off by using a Vital 2, and I first pass my suture through the proximal stump of the tendon. I then get my fellow or assistant to apply traction for about 2 to 3 minutes. And the reason for this is, one, when you rupture the tendon, the muscle sarcomeres contract. You want to release that contracture of the sarcomeres before you do your repair. Reason being is if you were to repair it without releasing the contraction, you may lose some of your tension as the sarcomeres relax after the repair. I then pass the suture through the distal stump, and then as you can see in this video, I use this coarse suture to oppose the tendon ends under direct visualization, and I restore my normal tension into the tendon. Now, they described that you can drape both feet in surgery, so you can get similar resting equinus on both feet. But I found with time that there's always some lengthening of this repair, and you always lose some equinus. So I usually tend to over-tighten by about the 5 degrees when I place this coarse suture. So once I'm happy with my resting tension, I proceed to reinforce this repair. And for this, I use Vicryl 0, and I use a Krakow whip stitch, which I run up and down the tendon. I then finish this off with a circumferential suture using Vicryl 3.0. And we know from the hand literature, by adding this kind of circumferential suture, we increase strength by 20%, but also it tucks in those frayed ends, which could irritate the skin incision. What about PRP? So I used to use it in the past, but there's absolutely no evidence in the literature which shows that this benefits the outcome. So it's an unnecessary cost, and I no longer use this. Now, to me, also very important, you've got to close the peritoneum. This prevents adhesions, which allows for better gliding of the tendon, gives proprioception to the tendon, and it's an important part of the blood supply. So I use a absorbable Vicryl 4.0, either with a running or interrupted suture. And then finally, my skin incision, I like using a subcuticular absorbable monochrome. I then place the leg in a well-padded plaster cast, and you can see we've restored the resting equinus, and maybe even a little bit more as compared to the opposite side. As I mentioned earlier, be careful of the insertional rupture, because you need to diagnose this before you get to the OR, because you may need specialized fixation. I prefer using suture anchors. This is that previous x-ray I showed you of an insertional rupture. And I used, as I mentioned, 2 suture anchors. I run a Krakow whip stitch along each side of it, and I use that to reattach it back onto the calcaneus. With regards to post-operative protocol, I think one of the biggest game changers in Achilles ruptures has been so-called functional rehabilitation. And what this basically means, you want to get them weight-bearing as soon as possible and moving as soon as possible. And what this does, it increases the production of type 1 collagen instead of collagen type 3. And this is a far stronger type collagen, and it doesn't rupture as easy. Now, I've got two things where I disagree with in the functional rehabilitation. The first one being is where some of the protocols want you to get the patient weight bearing day 1 after surgery. Now, we know one of the main complications is wound complications. Now, to me, it doesn't make sense to risk getting swelling and edema of this incision in the early stages of healing. So for the first 2 weeks, my patients have got strict bed rest and elevation and are non-weight bearing. At 2 weeks, they can start weight bearing as tolerated. And at 4 weeks, they go into a boot with 2 heel wedges. Now, this is also where I change. A lot of the programs will then start removing these wedges as the rehab progresses. I personally feel that it's important to maintain these wedges because you've gone through the risk and effort to make sure that you've opposed these tendon ends to get the correct tendon tension. And the last thing you want to do is stretch out your repair. Yes, I agree, you need to load them, they need to weight bear, and they need to move, but you can move them passively and actively without having to take out these wedges. At 10 weeks, they come out of their boot. And again, I give them a 15mm heel raise, which they put in either a cross trainer or a running shoe for up to 3 months after coming out of the boot. So as you can see, I protect them with some sort of wedge for up to 6 months, and I'll explain why. Most of my patients are allowed to start cutting sports at 6 months. And it's important to inform your patient that the full extent of the recovery can take 9 months to a year. So as I mentioned, I protect my patients for up to 6 months with some sort of repair, with some sort of wedge, sorry. So, and the reason for this was, it always concerned me, why does the literature show similar functional outcomes at 1 year out when you compare surgery to conservative management? So it just didn't make sense that surgically you can see that you've opposed the tendon ends, you've restored the tension in the tendon, whereas conservative, you kind of hope that the tendon ends are touching and they heal in the correct tension. Now, I always thought to myself, we are overdoing it, we're stretching out our repairs. Now, subsequently, there's some good studies which have confirmed this. And this is a nice visual study. So basically, at the time of the surgical repair, they implanted these tantalum beads into the Achilles tendon, and then they x-rayed these patients for up to a year. And they had 3 groups, and the groups included both patients who were totally non-weight bearing, no motion, to a group which was the so-called functional rehabilitation. And all 3 groups had significant lengthening of the Achilles tendon for the first 6 months. And for this reason, I think it's important to try and protect this repair and tension that we've gone to the trouble of getting while this tissue matures and strengthens up. That's the reason I protect it for up to 6 months. So complication-wise, what we're always concerned about is delayed wound healing and infection. You can try and minimize this, first of all, with meticulous soft tissue handling. And we always teach our registrars and fellows no sharp retraction and always blunt, deep retraction. Also, again, avoid swelling the first 2 weeks. You don't want to risk wound problems at that stage. And again, please beware in the diabetics and the smokers. DVT can also be a serious complication as it can result in pulmonary embolism and a death. And we've actually done numerous studies looking at DVTs in foot and ankle surgery, of which one of our first studies was the incidence in Achilles ruptures. And we've come up with recommendations for DVT prophylaxis and basically any high-risk surgery, and these include your Achilles ruptures as well as your adult-acquired flat foot reconstruction, or any patient requiring 4 weeks or more of cast immobilization and or non-weight bearing should get prophylaxis. So what does the evidence say? So as I mentioned earlier, the game changer in Achilles management is so-called functional rehabilitation. But there are some still statistically significant findings. Returning to work is definitely quicker in those patients operated, up to 3 weeks sooner. And although the functional outcome is similar at 1 year, if you look at specific activities, the operative patients do better, such as drop, jump, and hopping. Now, for a sports person, this is quite important. Now, also, some of the results have been found not to be statistically significant, but they are superior. So if we look here at plantar flexion strength, at this bar graph at the bottom, so they assessed plantar flexion strength for up to 2 years, and you can see consistently that the operated patient always had slightly more strength. And again, for the sportsman, this slight increase in strength can be very important. And again, with this functional rehabilitation, the concern of re-rupture rate with conservative management has significantly dropped and is almost similar to surgical management. But if you look at every single study, the surgical group always had less re-ruptures as compared to conservative. Now, mathematically, it's not important, but if you are those 2 patients in the conservative group who do happen to get that re-rupture, that is significant to you. So with this all in mind, it's important to weigh up the benefits of the surgery with the risks of the soft tissue complications. And the current literature shows that this is at about 5%. So in conclusion, it's important that you discuss both management options with the patient, and together you guys decide on what's the appropriate option for that patient. I recommend surgery in the middle-aged active patient who has no comorbidities. I think it's very important to be careful and be meticulous with soft tissue. I definitely say use an absorbable suture, repair the paratenon. Those first 2 weeks, try and avoid any kind of swelling. It will limit your wound complications. And whatever you do, load it and move it, but protect it for up to 6 months. Thank you very much.